All right, everybody. So welcome to this month's AI and Medicine Journal Club. This month, we're going to be talking about explainable AI, specifically in dermatology. For anybody who's not familiar with me, my name is Louis Shendowich. I'm a hematology and oncology fellow at MedStar Georgetown University Hospital. Um, in regards to this specific presentation, we're going to have two specific learning objectives. The first is to differentiate between black box models and interpretable AI models, specifically in the context of dermatology. Then we're going to understand the clinical role of explainable AI. To do this, we're going to be going through three separate parts. The first one is going to be the clinical context on why diagnosis can be very challenging in dermatology. The second is going to be going through two specific models, DermaSensor, which is a black box model, and DermX, which is an interpretable model. The third part is going to be the clinical implications. And really, we're going to be focusing on when is explainable AI most appropriate to use. So a little bit of history or a little bit of clinical background. Skin cancer is the most common cancer in the United States. There's over 5.5 million skin cancer cases per year. And there's approximately 105,000 newly invasive melanoma cases annually. The annual projected death is around 8,400 in 2025. And one of the most important parts of skin cancer is that early detection is critical. The 5-year survival is greater than 99% for localized melanoma. However, at 5 years, it falls to 35% if you have distant or metastatic disease. Really, what ends up happening is a lot of the patients or people will have a skin lesion and they'll present to their primary care doctor or their dermatologist, and they'll need a skin biopsy. However, most biopsy lesions are benign. They did studies on this, which approximately resulted in 15 benign skin lesions biopsied per one melanoma detected or diagnosed. Additionally, the clinical exam has limited accuracy. Although we're taught in medical school the A, B, C, D, E of melanoma, which you can see on the right, the sensitivity is not that great. For the dermatologist, it's 76% with a specificity of 89%. However, the PCP, the sensitivity is much lower. It's around 37.5%. So there's a clear gap in knowledge and also in the ability to diagnose these specific conditions between the PCP and the dermatologists. Now, let's talk a little bit about AI specifically in dermatology. And it really starts in around 2017 when they started to use black box AI models. And one of the first ones to be developed is something called DermaSense. This was right around 2021 when the first paper was released, and it received FDA de novo authorization or clearance in 2024. That's the model that we're going to be discussing today in regards to the black box AI model. There's a second part of this, which is the explainable AI model, which really started around 2022, and it continues to current day. And there have been several explainable AI models that have been published. However, the one that we are going to discuss today is DermX, and that one was published in 2023. Some of the future for artificial intelligence in dermatology involves clinical decision support and treatment effect modeling, not just diagnosis and skin lesion triaging. So let's start with DermaSensor. This is going to be our black box model that was one of the first ones that was developed. The goal of this specific model is to improve early detection of skin cancer through non-invasive point-of-care risk stratification. And really what that means is that it wants to enable primary care providers to triage specific patients and skin lesions for biopsy and referral to the dermatologists. The specific model of DermaSensor involves an ensemble of neural networks, and specifically two different types. The first is a feature-based learning, which takes structured spectral patterns. What does that mean? It means really we tell the model what is important, what features are important. And it also incorporates a second part, which is a deep learning model. And that is really the waveform pattern recognition. Some of the inputs that we put into this model is an elastic scattering spectroscopy, which is a specific wavelength light between 360 and 810 nanometers. This is not just a picture that you take with your phone. This is a special device, and the output that it provides is two specific risk classifications, a low risk and a high risk. And that presents as monitor or investigate further. That's how you'll see it on the specific device itself. And then in addition to that, you'll get a similarity score to malignant patterns. So what does this really look like in practice? If you take an ESS signal and you put it on a graph, you can see here the example on the top right. You have a clear difference between the dotted line, the dotted red line, which is specifically a malignant melanocyte, and a benign melanocyte, which is really the solid blue line. You see a separation of the curves in the early as well as the late wavelengths. On the bottom right hand, you can see the specific device that DermaSense has actually developed, and then the two specific outputs that you may receive. The first one, which is monitor, that implies low risk, and the second is investigate further with that specific number on the bottom. So let's talk very briefly about the model architecture and how they actually designed it and how they use it. So like I said before, really the input is this spectral signal input, the ESS signal. And the first step, what it does is actually noise reduction and normalization across the wavelengths. It's really just signal processing to prepare it to be inserted into the specific models. And that's where it breaks off into two different model types. And like we discussed last slide, the first one is a feature-based neural network, and that really learns the engineered spectral features. And the second one is the deep neural network, and this is based on a modified ResNet, which is basically, it learns the raw spectral features and it really captures the complex nonlinear patterns. So this is an example of a deep neural network, the modified ResNet. And they take these two models and they combine it together to give an ensemble prediction. And what that ensemble prediction does is that it's combined and it gives you a clinical output. The two examples that we gave before, or the two options that they have as an output, is monitor or investigate further. So in regards to some of the results, outputs, and performance of DermaSensor, it is quite accurate. The performance or the clinical validation had a sensitivity of around 97% and a specificity around 26%. So what that means is that there is a high false positive rate. However, the negative predictive value is going to be very strong, and that's around 89.6%. So clinically, what does that mean? It means that this specific tool and this model has a strong ability to rule out malignancy. Now, compared to dermatologists, the sensitivity is similar. The device was around 97, dermatologists around 96. However, the specificity is lower. So this is not a replacement for dermatologists. And the interpretation, what does this mean clinically? It prioritizes not missing cancers. That's really what it wants to do. It wants to serve as a triage tool so that you're not missing anything that could be worrying, any specific skin lesion. And it accepts a lower specificity so that it can be more sensitive. And that's really what that means, is that there's going to be more biopsies and referrals. Now, why is DermaSensor a black box model? Well, the internal logic is not necessarily clear. It's opaque. And the deep neural network is not that interpretable. So there's no feature level outputs. We don't know what is going on within the model that is leading to this specific recommendation of monitor or investigate further. Additionally, the clinical impact, or why is this important, is really that it improves safety and detection at the cost of more unnecessary biopsy. And that's the critical point of DermaSensor. And that's the kind of thing that I think everybody should be aware of when they're using this specific tool. It is an adjunctive tool for triage. It is not a replacement of the clinician, and it is not a diagnostic tool. This did receive FDA de novo clearance in 2024 as a Class 2 adjunctive diagnostic device, specifically for evaluating suspicious skin lesions. It is not a standalone diagnostic tool. So that leads us to our next model and our next concept, which is really explainability and artificial intelligence. And to understand explainabilities, you have to understand some of the barriers to implementation of these models, and specifically the black box models, which is the first models that were developed. So the first barrier is the clinician trust. Can the doctors really trust the output of this model? The second is the transparency. Not only can the doctors trust it, but there is a level of medical legal liability that goes along with certain outputs. Along with transparency is the FDA recommendations, and the FDA does recommend that all of these models need to be transparent for clinical deployment. The third part is that the decisions are often high stakes and irreversible. And so what do clinicians need to know? There's really two things that they need to know. Why was this prediction made, and does it apply to my specific patient? And that's where explainability really takes foothold. It bridges the gap between model output and clinical reasoning. It enables validation, trust, and also safe decision making. And that's critical for explainable AI. And on the bottom here, you can see an example of the difference in one of the trade-offs between interpretability and accuracy. On the left hand, you can see some of the most common models in modern artificial intelligence clinical models, and they're usually black box models, such as CNNs, which are convolutional neural networks, deep learning, as well as LLMs, which can be also in regards to GPT, as we said before. On the right-hand side, you can see what's an example of a white box model, and these are really just inherently interpretable models. They have a very high level interpretability, and sometimes there is a trade-off for accuracy. Not always, but sometimes there is, depending upon the complexity of the data and the clinical question that is asked. An example could be linear or logistic regressions. So just some basics of explainability in artificial intelligence. There's three areas in which you can look at explainability. The first is before the model itself, and that's really at the data level. Can I trust the data that the model was built upon? Is there bias within the data set, and does the data set match the population in which I'm using the model for? The second is inside of the model. How does the model make the decision? And this is really where we talk about the interpretability of the model. Is there a direct feature outcome relationship like a linear model, or is it something that you do not necessarily understand and cannot really clearly follow? The third part is after the model, and that's really the output level. And that goes along with, can I interpret this prediction? The explanation of the individual outputs. And that's where you're going to see some of the specific examples that are coming up next. That's Grad-CAM, SHAP, and LLMs. So now let's talk about our first explainable model, which is DermX. And DermX was developed, or the reason they developed, was that it was supposed to be a general dermatologic diagnostic model. It's not a cancer-specific model, but it's meant for all different types of dermatologic diseases. The goal is to explain the diagnosis, not just flag the risk, and it also is meant to mimic how dermatologists think. It uses a process of describing skin lesion features to inform the specific diagnosis. The model that it uses, unlike the deep neural network, is a CNN. So a CNN extracts features from the image itself. And in this specific model, it uses a hybrid in-model explainability feature. So it's a structured deep learning. Some of the inputs for this specific model, DermX, is the actual images itself. So on the bottom left-hand side, you can see an example of a patient who has taken a picture of a specific skin lesion on their nose. You can see the input is just the image itself. And on the right-hand side, you can see the examples of the output. And there's going to be three different outputs. The first one is that it's going to predict the diagnosis. And on the top, you can see here it predicts actinic keratosis. The second output is the characteristic head. So that's basically the explanation element to this model. It predicts an explanation, and it incorporates that into the final diagnosis. And then the third output is what Derm Plus uses, which is a Grad-CAM or a heat map to identify the specific areas that the model is paying attention to come up with these characteristics. So you see the plaque, it is looking at one area, the scale, it's looking at another area, and sun damage, it identifies another specific area. This is going to be the overview of DermX. And again, the DermX is the first generation model. DermX Plus is the second generation model. And really the only difference, the only meaningful difference is really that you can have this heat map to see where the model is identifying the area that's driving the model, driving the prediction. So it uses a technique called Grad-CAM. In Grad-CAM, on the bottom right here, you see a picture of it. It is a heat map used in deep learning to visualize what parts of the image a neural network focuses on when it's making a decision. It generates a feature-specific attention map. So just like we said on the right-hand side, you can see it for each one of the specific characteristics. And you can see how this might be clinically helpful for a physician who's using this tool to understand, oh, okay, this is the specific characteristic that the model is seeing, and that is what's driving the diagnosis. The performance is excellent. The F1 score is 0.79, and that's actually comparable to the dermatologist level classification. What does that mean? It means that it indicates a strong overall classification performance, and what it is detecting is truly the disease. It's not necessarily cancers, as I have written here, but it could be any disease that it is listed in its diagnosis. It's not also overcalling excessively. It has reasonable precision, and that's what the F1 score actually measures. It's a balance between avoiding false positives and avoiding false negatives. So it's about, the F1 score captures overdiagnosis and mixed cancers and combines it into a single score of performance, a performance metric. Now, some of the limitations of DermX is that it is really using subjective feature labels. It's trained on a dermatologic annotated features. So the dermatologist annotates features, which is used in the specific model, and that can introduce a layer of labeling bias. The next is that the explanation does not necessarily mean true reasoning. The predicted features, and again, it's a predicted features, are presented as explanations, but they may not reflect what's actually driving the model's interior thoughts and the model's interior decision making. And then the third one is that it could have potentially limited generalizability. So the performance depends on the training data. And you have to really examine the skin tone, which you might consider might be a big variable in these types of models, the image quality, the pictures that is taken, the camera that's used, and the clinical setting. All of these things could limit the external validity of this specific model, and that needs follow-up in further studies. So that leads us to the final part of this presentation, which is really just an overview of this third paper, which is the Explainable AI Double-Edged Sword. And the goal of this specific paper is to evaluate how different forms of explainable AI affect human diagnostic decision-making, specifically in dermatology. It wants to test whether explainable AI improves the diagnostic accuracy, and it wants to examine whether explainable AI affects the general public and the primary care providers differently. So it's really looking at that interaction between the humans and the artificial intelligence. It uses a human AI diagnostic system that is built around image-based dermatology, and they have two specific studies. The first one is going to be for the general public, and that involved around 623 patients, or not patients, but people, and they were given 12 diagnostic choice questions. They were given a prompt and a question, and they were supposed to insert an answer. The second study was a differential diagnosis, and that differential diagnosis was specifically for the primary care providers. So unlike the study one, which just asked if it was melanoma or a nevus, the study two was asking for a specific diagnosis. Again, they were given 12 questions. And what they did is two specific um, variables. The first factor that they evaluated for was different explainability models. The second factor is that if the AI model gave them a prediction first and then they did their own output second, how did that affect the outcome and the accuracy? So it's really just seeing if the AI influences the diagnostic accuracy, and it also affects seeing how it affects the confidence, calibration, and the susceptibility to incorrect AI guidance. But what I want to briefly talk about is some of the explainability methods that were used in this study. And I think they're important because you will likely see them in dermatologic models moving forward. The first one is Grad-CAM, and we've already seen this. Like we talked about before, Grad-CAM is a heat map of where the model looks. The second one is CBIR, and basically what this is that it analyzes the image, the lesion on the skin, and then it pulls from its history or from its memory similar clinical cases that look similar to the picture that they see right now. So what does the actual lesion look similar to? And then the third element, or the third explainability method, is an LLM. And this LLM is basically, it generates a clinical style explanation of why this specific lesion is the AI predicted diagnosis. So it could, for instance, in this specific example, the AI prediction is a melanocytic nevus. And so the lesion has well-defined and smooth edges suggesting benign in nature. The pigmentation is uniform with light brown and tan color typical of a nevus. You can see how all of these descriptions and all of the words may explain how it got to this specific diagnosis. And so just some of the key findings for this specific study, because it was a complicated study, but I do want to really hammer down the findings what it did find. And the first thing is that AI assistance improves diagnostic accuracy overall. Across the study, including the general public and the PCPs, it improved the diagnostic accuracy. The second finding is that the LLM explanations really amplify the outcomes, both the good and the bad. And that's why this paper is called the double-edged sword, because the LLM explanations reinforce the AI's answer more than the independent human judgment. And so what that means is that when the AI prediction is correct, the physician or the person selecting the answer or writing down the answer, the accuracy increased by an average around 7%. But however, when the AI was wrong, the human selected the incorrect answer much more frequently. So it really decreased it by 21%. And that leads to the third finding, which is that an AI first presentation increases the error rate, usually due to anchoring. So the exposure to the AI diagnostic anchors really anchors the decision and it propagates the error. So when you see an AI prediction, that is really playing into the overall judgment of the physician and influencing them one way or the other very strongly. And that kind of leads us to our concluding slide, which is really just putting all three of these papers into context. Starting from the very beginning, which is DermaSensor. And this is really the classic black box model. It's really focusing on high performance without any interpretability, and it is totally acceptable to use as a triage tool. The next model that we talked about was an interpretable model. And the most important question, or the point of tension that we tried to answer, is performance alone sufficient for clinical use? And the DermX study really showed us that explainability can be added without sacrificing performance. And then the third part, which is the Explainable AI Double-Edged Sword, which was quite a complicated study, but really the takeaway is that explainability can improve trust, but not necessarily correct trust, and that it can also increase accuracy. So there are some key take-home points for all three of these. The first is that you know the value of explainability depends on the clinical task. For instance, triage performance matters. Diagnosis interpretation helps. And then for the final one, which is the clinical decision, certain explainability tools can be helpful, but it can also lead to um, overconfidence in the specific model and the AI output. And that really leads us to our discussion. And I want to focus on 3 or 4 questions. I first want to open it up to the group to see if there's any specific questions that we would like to talk about before we go on to these ones. All right, concludes this month's AI Journal Club. Again, we talked about explainable AI in dermatology and how it progressed from black box to interpretable models and some of the benefits and downsides of using explainable AI.